Let me invite the panelists. Dr. Deepak Shukla is here. Yeah. Dr. Deepak Shukla is the consultant in Manipal Hospital, Jaipur. Dr. Anu, Ajay. Dr. Anu is a medical oncologist with SNIMS Medical College, Jaipur. Dr. Amit Verma is here. He's the director of Dr. A.B. Institute of Personalized Cancer Center. Dr. Ankit Agrawal. Dr. Rakesh Pinati is here. Rakesh, you can come with the tea. No issues. Dr. Ashish Joshi, I think I saw Dr. Joshi somewhere. Can someone please call? I think he has a parallel session going on. And Dr. Manoj Mahajan, a dear friend of mine, is a director in Pacific Medical College in Udaipur. So first of all, I apologize. When this topic came to me and I made these slides, somehow when the topic came as uncommon mutation, I assumed it is EGFR uncommon mutations. I didn't thought that it would be about ROS red. In fact, I was having a discussion with Dr. Kumar, how would you define uncommon mutations? And that time I was like, uncommon to ROS red bhi hota hai. तो ऐसा थोड़ी उसको अनकॉमन बोलेंगे. अनकॉमन होता है EGFR वाला अनकॉमन. So I'm sorry if you have come prepared for that. So let me have a how do you define uncommon mutations? And we'll start with Rakesh. Rakesh, how do you define uncommon? And let's for this specific panel we talk about EGFR mutations. How do you say this is uncommon? I think it's not working.
So when we look at EGFR as a driver mutations, what we are looking at is the major common mutations of the exon 19 deletion, L858R, exon 21. The major uncommon mutations and minor uncommon mutations is what I see. And these are the exon 20 mutations. And the very uncommon, minor uncommon mutations include those in the exon 20 insertion and all those things. So,
okay. Dr. Manoj, in your practice, how many compound or complex mutations you see? Which means that uncommon is with another uncommon, or the uncommon is with a sensitizing common mutations?
Around, I say 3 to 4%, not more than that.
Okay, 3 to 4%. Okay. So let me just talk about, when you look at whole EGFR as a gamut, and this question is for Dr. Verma, this whole EGFR as a gamut, which amongst the uncommon, you would say that these are the most commonest among the uncommon EGFR mutations? Can we have the mic?
G791X and G861Q, they are the common uncommon mutations normally encountered in our clinical practice, but it can be experience dependent actually.
Okay. Ashish, do you see that whenever you order an NGS that uncommon mutations are covered, do you think it is relevant to cover them in today's era, or you are happy that only sensitizing mutation if I get, I'm okay with it?
No, I think it's very important that we have complete encyclopedia of individual cancer, because for number one is that there could be an emerging new drug which could be there in the pipeline, maybe currently the patient may not afford, and it just gives you the prognostication as to how the patient is going to behave. And even in my experience, the L682, that's the one which I have seen most of the uncommon EGFR mutations in my practice.
Okay, so I think the message is that when we are now doing NGS, you're more seeing this uncommon mutations with respect to it. Dr. Shruti is here. Shruti, this is your own work. Do you want to speak about what was the incidence and which were the common mutations and why was this work done? And this was published way back in 2019, but I know the work was done in 17 and 18 primarily.
Yeah, so the paper gives the entire description of the incidence of these mutations in Tata Memorial Hospital. Mainly, we wanted to see which are the compound mutations, and really do the compound mutations respond to TKIs, because we know that the certain uncommon EGFR mutations would not respond to TKI. But many a times we face compound mutations out of which one is sensitive, one is insensitive. So we found that when T790M is present in the primary tissue, which has not been exposed to EGFR agents. At that time, the sensitizing mutation dominates, and those patients derive benefit from TKI therapy. So that was the clinical experience, and we wanted to see how it comes out, with the entire statistics.
Anu, is that and Dr. Is that your also experience that compound mutations do better than the single one? Like if you have only G719X versus having G719X plus something, even like let's say L861Q, they would do better than G719?
Yes, sir, I agree. If it is compound, then they do better with TKIs. But if it is alone, then they don't do well with TKI.
And actually, this is something which has come across all publications which I saw, that if it's compound, I couldn't get the mechanism why it happens. Any idea among the panelists why this happened, that you have one which is bad, if the other alone is bad, but if you're both together, somehow even the first generation TKIs do better.
So actually the classification as to type 1, type 2, type 3 actually was made on the basis of a Lancet paper in 2015.
Yeah.
Okay, and recently in Nature, I think last year there was a paper published which defined the exact type of means not on the type of mutation, but based on the EGFR structure, they tried to define the type of mutation. So if we look into that paper, there is clear biological rationale as to why some of these co-mutations do well as compared to single mutations alone.
That's the correct point. And this actually, the coloring for the symbol is based on that Nature's paper, where you see that classic, like they would actually behave like the sensitizing mutations. The white ones, which I have not shown here, actually would behave like the T790M. The green ones are which would behave like an exon 20 insertions. What you're saying is correct. This was the Nature's classification which was given. And we have this data from another around 17 centers, which was presented by Dr. Manu Prasad in the ASCO of 2020, which also confirms that G719M amongst the other things remains one of the most common mutations. And I think this is what Dr. Deepak was leading to, the Lux analysis or Lux two studies, in which and we'll spend a minute on this because a lot more discussion on the management role will be happening. So when we look at this study, you could see that there are 100 uncommon mutations, 75 receive afatinib, out of which the group 1 is, as correctly pointed out, the ones with point mutation and duplications. Group 2 is actually T790M. Group 3 is exon 20 insertions and chemotherapy. Now, we'll have this at the back of the mind that there are 4 groups in this study. One group is point mutation, one T790M, one is exon 20 insertion. All of these have received afatinib. The authors have never given such grouping in the chemotherapy arms. That whole chemotherapy has been given as a single group. This data actually is from the multiple Lux studies, randomized studies. So we could actually presume that similar characteristics would have been in the other arm also. And we'll keep that in mind. And I'll start from Dr. Joshi here. Exon 18 G719X has come, and the patient has come to you for the first line therapy. Which among these would be your choice and why?
This is again one uncommon mutation, notorious not to respond to the conventional TKIs. So typically go with chemotherapy plus gefitinib.
So you want to go with chemotherapy plus gefitinib. Dr. Verma, what would be your choice in this?
So I think the answer should not be that complex because.
Well, that's okay. Let's forget that complex and let's focus on G719.
Okay, so I think I would go with the third generation straight away.
So you want to go with osimertinib?
Yeah.
So gefitinib plus chemotherapy or afatinib.
Okay, so now we have gefitinib plus chemotherapy, osimertinib, and a choice of gefitinib or afatinib. Anu?
So same, gefitinib plus chemotherapy.
Okay. I actually expected many answers to be in favor of afatinib, so slides have been arranged in that way. That's okay.
I think chemo should be an option, and I'll combine it with your TKI.
Okay, so gefitinib plus chemotherapy.
I would prefer afatinib
Okay.
now as generic is available, and
Okay.
if affording, then osimertinib.
Okay.
I think the best prospective data is for afatinib, sir. I would probably prefer afatinib for it.
Okay. Okay. Let me have a call of hands. Many medical uncles there. How many would use afatinib in this situation? And I'll just, for those who are looking at WhatsApp, it is G719X. So afatinib, how many for afatinib? Okay. And how many for geftinib plus chemotherapy? Oh, so there is a good divide. How many for osimertinib? Okay, that's good for osimertinib also. Okay, okay. Mansi actually is saying that she would probably see the affordability of the patient. And if it's affordable, osimertinib, if not, then afatinib. So I actually dissected the evidence for this, and this is a very good meta-analysis of whatever treatments. And I would recommend people to read this meta-analysis. This guy has actually formulated not only all the retrospective series, the prospective, but also the case reports which have gone and got published in 2022. And what you could see is what the only prospective data which comes from Yang study, which both Rakesh and Ankit alluded to, were about afatinib. And you would see 18 patients of afatinib of G719 was taken. The response rate was 77.8%. Median PS was 13.8 and median OS is 26.9. If you look at all other studies, these are mainly done with first-line TKI. And you could see a characteristic thing, if there is compound mutations are there, then you could see that the responses are upwards of 70%. But if it's not there, the responses are between 20 to 40%. And things have to be taken with a pinch of salt because many of these are retrospective studies. You don't know how many of them did resist in the way the resist has to be done. Now the question is, quite a few of us wanted to give afatinib. And until very recently, I also was of that opinion. And when I actually looked at the data, if you see this analysis should have been for group 1, which was the G791. What happened in those patients versus in G791 chemotherapy, what happened in those patients? The p-value in Lancet for this paper is significant, but what it shows is that group 1 did the best. Now we remember that group 1 was the point mutation group. Group 2, which is the 2 lighter of the blue, did the worst, that is actually T790M with afatinib. The group 3, which is the insertion, also did the worst. Surprisingly, and I could see that many of them wanted to use chemotherapy. Chemotherapy was there. In fact, it's there, and it becomes a better surprise when you actually look at the overall survival data for the Lux studies, when actually, if you see, chemotherapy did much better in terms of overall survival. And if you look at the figure, it is 20 months versus 30 months. Which, looking at things, the idea goes that probably using chemotherapy in G719 would not be such a bad idea. Actually, I thought that it may so have happened that patients who took afatinib may not have taken subsequent therapy, which we know that happens in TK groups. And chemotherapy, all may have taken subsequent therapy. And that's the reason why I posted that data there. That no, it happened in spite of 60% of the patient in afatinib taking subsequent therapy, as opposed to 48% in chemotherapy. So I couldn't dissect that much further. Yeah.
So in the type 1 mutation in this paper also they have the 3 uncommon mutations in the type 1. They have mentioned one of the mutation benefited more as compared to second, as compared to third. If you look in the same data for osimertinib, it is the other way around. The mutation.
Correct. That's the reason why I have not taken all of them together. We have started with G719M and we'll dissect all the 3 in the same manner. And this is what was the response. The first response is for chemotherapy, which shows that there's a response rate of around 30%. And this is another data which I got from ESMO, this is never come in public domain as a publication, but this actually correlates with what was the data presented and seen in the Lancet, where you could see that patients who receive chemotherapy have a median OS of 27 months versus TKI, though the TKI here, basically that's the reason I highlight first line TKI, would have a median OS of 17 months. So the data is showing that maybe G719M, there is a thought that chemotherapy addition or giving might be beneficial. And hence, there are only 2 studies done. One was our study, which I couldn't do the analysis. So I went to the Japanese study to look after whether they took G719 in the session. And I was surprised to see that they actually, the other group, predominantly is of G719A, C, and S patients. And when we look at the data, and this is the update which came in JCO 2020, to actually see that the hazard ratio is 0.7 in favor of Geftinib plus chemotherapy versus Geftinib. I agree that other part is not Afatinib, it is Geftinib. So looking at this, and this is what the point which was made, and let's focus on the upper row of G719X. This is the phase 2 data from Korea on osimertinib. You could see that the response rate is 53%. So, and this response rate remains 53% even in the unicorn data, which is the real world data of uncommon mutations with osimertinib. Looking at all these things, I think all what panelist options which were given were actually correct. You could have used afatinib. Those who wanted to use Geftinib plus chemotherapy also, that it made a sense. It also made a sense to use osimertinib. If you ask for after dissecting all that, I thought that probably TKI plus chemo using upfront and reserving osimertinib for later, because the data of osimertinib, actually 40% of these patients were in the subsequent line would have been making sense in exon 18. Any comments from any of the panelists on this, or we'll move on to the next uncommon mutation? So if you get S768I, would the choices remain the same or they would be different?
Same, sir.
Same? Any change?
Same.
Same? Anu, any change?
I think this time I'd say afatinib.
Okay, this time you want to say afatinib. Okay. Anything, Dr. Verma and Dr. Joshi? Same?
Yeah,
Same. Okay.
chemo plus TKI.
Okay, anything, Mansi? Again, afatinib or osimertinib, depending on affordability? Shruti? Okay. No.
I'm not sure about osimertinib.
Okay, you are
The
not.
data was very, I mean, whatever data I read, it was not a lot of data.
Okay. Okay. So this is again that from that same meta-analysis, and you could see that afatinib, 8 patients were all responded. That's 100% for this mutation with afatinib. First generation, even if there are compounding, here the response is only 30%. You look at the response with chemotherapy is only 30%. And when you look again, now we are talking about 768I, so that is the last row. You could again see it is around 30 to 40%. So whatever the limited literature we have, it seems that probably in this, probably I can't say specifically, probably for this mutation, probably giving afatinib first on the limited evidence which we have could probably make a sense. And without wasting time, we'll go for the exon 21 86IQ. Any thoughts? Options remain the same or you want to change?
Same, sir.
Okay, so let's try to wrap up the session in next 2 minutes. So when you look at this, again, analysis, you could see that afatinib gives 56% response rate. I want you to pay attention on the median PFS with afatinib. It is 8.2 months for this mutation. If you look at this with respect to the other mutation, it was 14 months. With respect to this mutation, again, it was 14 months. Clearly suggesting that for this mutation, we cannot draw any firm conclusions on such a small numbers, but there's a hint that the response rates also drops and the PFS also drops. If you see, if the first line TKI is there with the compounding, the responses again are high. Without compounding, responses are 46%. What I found interesting is this. If you use osimertinib for 861Q, the response rate was 78%. And we can very well say that this is only 9 patient data. And Unicorn actually comes here to help with the large data. And you could see that 86QIQ, it's a slightly bigger data of 19%, but we must understand that all data of uncommon mutations have been based on less than 20 patients. You could see that the response rate is around 80% with this. Yeah. Again, I thought that probably again, because this is very limited data, probably if you get an 86Q, L861Q, probably giving osimertinib maybe. So the reason why I wanted to bring this is like G719X, the data suggests that somewhere chemotherapy needs to be integrated. The other mutations, afatinib is doing very well. For this mutation specifically, it seems that if you give osimertinib, they probably would do well. And that was my conclusion. if any one of the panelists has any comments, I would.
Yeah, so just regarding this last mutation we mentioned, I had
Yeah.
one patient just 3 months back started him on osimertinib
Yeah.
with this literature
Okay.
review. Progressed in 2 months. Progressed in 2.5 months and now on pemetrexed
Okay.
carboplatin.
He's doing well on Pulmonology.
Yes, there is a response.
Okay.
Any experience on generic hepatitis?
I don't use much of afatinib.
Okay.
I'm a fan of Jeftinib plus chemotherapy. Either that, if no, and affording them side directly osimertinib. I have some amount of experience of using lesser doses of afatinib in patients who are in head and neck cancer in second and third line. But with full doses of afatinib, none of my patients have tolerated.
Actually, one of my patient had a CNS meds
Okay.
and almost 5 years down the line
Oh.
patient with hepatitis.
Okay.
Upfront CNS meds and EGFR mutation positive. Common mutation, still like 5 years, the patient is still there. I think it was
So any analysis you have done for the PEM carbogepitinib for the uncommon mutation means
So I'm planning to do it on Monday. Actually, the Wi-Fi was not good, so I couldn't get the sheet from my computer. That's the reason I couldn't show the data. But I was all set in the night to do that analysis and see what comes in our paper. Okay, thanks. Any question anyone has?
Dr. Vijay,
Yeah.
any role of osimertinib with chemotherapy? Any subset which you will recommend that?
So I actually, before the results came for those two phase 2s of osimertinib plus bev and osimertinib chemo, I used to be actually I thought that would be one of the better, but unfortunately, as you would be also recently we have the results for OC versus OC bev and OC versus OC chemo. Both have come out to be negative. So I'm not sure chemotherapy adds more on to osimertinib. I'm not sure.
Dr. Vijay, any dose changes of osimertinib in their uncommon mutation?
So not our experience is very small with respect to uncommon mutations, and in uncommon and with osimertinib also is much smaller.
Right.
So I cannot tell you that. I can tell you another thing which is not for uncommon mutations. We are at present in Tata having a phase 2 single arm study where we think thrice in a week dosing of osimertinib should be sufficient.
Okay.
Okay, that is based on our PK/PD analysis which we done in our lab, and that phase 2 is going on at present.
So the osimertinib that we are using for the common EGFR mutation, if there is a upfront brain metastases are there, so is there any role definitive 160 milligram per day? Can we use?
So I think you alluded to the JCO paper which came with osimertinib 160 mg. We are not doing that at present. In fact, at present I can tell this with you because we have. At present I'm leading in our group. We are doing a study in leptomeningeal metastasis in non-small cell lung cancer. The idea is that if the patient has leptomeningeal metastasis and if he's taking a third generation TKI, whether giving ITMTX benefits would benefit or not. In that, we are using a dose of 80 mg. And up till now, whichever patient we have started on osimertinib, so the study also enrolls ALK patient, osimertinib 80 mg itself has done well. Saying that, I have used osimertinib 160 mg in patients who progress and are T790M negative. So patients
Right.
progress on Jef chemo and T790M negative. So if you look at that analysis, which was in JCO, it shows that with 160 mg osimertinib in those patients, there was similar response, which was seen especially for leptomeningeal disease, but not for brain mets disease.
Right.
But tolerance does come an issue when you use 160 mg. The
Okay.
other strategy which was found in Bloom's study of using osimertinib plus bev for
Right.
leptomeningeal does much better than stepping the dose to 160.
Okay. One more small question. We routinely use gefitinib or erlotinib, first line or second line TKI, and then patient progress oligometastatically, mild symptomatically progress, and T790M0 mutation negative. And patient don't want to use chemotherapy. So for that subset of patient, is there any role of osimertinib?
So, not done a formal analysis, but this is a very tricky situation. In both our trials of Jeftinib versus Jeftinib plus chemotherapy, and the earliest trial of Jeftinib versus pemetrexed plus carboplatin. In both arms, if 100 patients progressed on Jeftinib, only 60 to 70% took treatment.
Right.
And one of the reason why, as opposed to that in other Pemetrexed, 95% patients took treatment. The major reason was exactly what you told. Patients had to be mildly symptomatic, and patients were not willing for oral chemotherapy. Now we actually tell them before start that you are going to progress at some point and we need to start you on chemotherapy. Because what we saw is that this patient group, when we sent them home and when they came back after 2 months, they were in a very poor general condition and
Yes.
that progressed extensively and we couldn't give anything. And
Yes.
that is why actually if you see quite a few first generation TKI trials, the PFS is higher with TKI, but the OS actually is on a slightly lower side. That is come in our TMH study also. So whether in these patients giving a higher dose of osimertinib would work, I'm not very sure. But there is data to that extent for leptomeningeal disease, and it's a JC
Only,
publication,
yes.
but I'm not sure about extracranial transformation.
Yes. Thank you, Vijay sir.
How commonly you are seeing de novo T790M upfront without means not a compound mutation?
So that is very rare for us to see. I would say 1% of and around. It's very rare for us. We have seen
Okay.
not very common.
Okay, so in addition means we discussed these NGS is having its TET as an issue. So so a patient with leptomeningeal mets, non-smoker, female. So do you see see a role of DDPCR for earlier starting of EGFR TKI? Means I have used personally. So just one of the such patient had a upfront T790M mutation.
So I understood your question. So I'll tell you what we do at what our unit policy is. If, as Dr. Verma also pointed out, if the patient progresses only in leptomeningeal site, or for some reason we want to have the tissue diagnosis from the craniospinal axis, we'll actually do a CSF. Try to get a cell block and submit that for this. So I actually see a role for doing that. We've been very successful. We have not been very successful, let me tell you. We have been able to identify only in 10-15% something. But the thing is, in those 10-15%, if you identify something, it changes a lot of things for that patient. I think one of the issue, another is like when you have this CSF cell blocks or CSF, you try to work on CSF like a liquid biopsy blood. Most of our, at least in our setup, the depth of coverages are not that great. They're like 1,000 or 2,000. To really get something useful in this, you have to dive deep. So you will require something like 10,000, 20,000 for such type of samples, which I think most of our labs are not doing. So that is a problem. In fact, we did a project of looking at liquid biopsy development in our lab. It took us pretty much long time to get synchronization up to 85%. We have not moved beyond that. If there are no other questions, we'll move on with the next session. Thank you all.